Dr. Javed, don't think you have more time because he was shorter, okay? Keep sticking your 15 plus 3 minutes. So Dr. Javed Raza, we're not going to introduce him again. You all know him. And he's going to talk about the outcomes and complications of the Roux-en-Y gastric bypass.
Okay, thank you, Carlos. And I realize that I'm between your lunch and morning sessions, so I'm going to stick to the time. So I've been given quite a wide topic, the outcomes and complications. So there are 2 lectures in their own right, but we'll try to go through both. So these are the learning objectives. The outcomes will look at procedures and evidence, medium term 1 to 5 years in terms of weight loss, long term 10 years plus. So that's the sort of definition we'll use in this, and we'll look at diabetes remission, weight loss, and the other comorbid conditions. When to come to complications, we'll talk about classification, early, late, and the main complications: internal hernia, ulcers, dumping syndrome, deficiencies, and some messages. So I'll try to be quick and brief. So I'm not going to talk about the numbers and what bariatric surgery does. So the common procedures we are going to talk about is Roux-en-Y gastric bypass, sleeve gastrectomy, OAGB, and some sort of biliopancreatic diversion. For the residents at the back, the bypass is combination of restrictive and malabsorptive, although it's less malabsorptive, more restrictive. Sleeve is purely restrictive, so to speak. One anastomosis, Dr. Atif said that it was predominantly malabsorptive. And biliopancreatic is hypoabsorptive, where you bypass majority of the small bowel with a very small common channel. And at the bottom you see the effectiveness of the treatment options available, which is from medical therapy to banding, which still we have patients, although we are not inserting them, we are dealing with patients, sleeve, Roux-en-Y, and then biliopancreatic diversion. So we have now the important studies to talk about. The SOS study, which is the most commonly quoted, has now data coming between 20 to 33 years. The Stampede trial from Phil Showers from Cleveland Clinic, we heard about it in the previous presentation, has a 5-year randomized controlled data, and SM BOSS 10-year, sleeve pass 10-year, and the American registry, MBS Squib registry, has over 130,000 patients, but this is from a 30-day mortality and immediate complication data. So we have a decent data now to talk about. So medium-term weight loss, and if we compare the sleeve and bypass, and someone has alluded to this before, so the sleeve has this is total body weight loss is 23% with sleeve, 28% with bypass, and if we look at the OAGB, it is superior in terms of weight loss to sleeve and bypass, something that I found it hard to believe, but I admit the data suggests so. I have to accept what Dr. Atif Shami tells me now in terms of weight loss. So long-term 10-year plus. So we have the randomized controlled trials. The SM BOSS trial, no significant difference between, as per protocol, Roux-en-Y gastric bypass which had a revision rate of 29%, sleeve had a revision rate of 29% versus Y, which has a revision rate of 5.5. So it's not only the weight loss, but the revision that happens later on or needed later on. The sleeve bypass, greater total weight loss, 26 versus 23, and less regain, 24 versus 35. So what's important is to know that even with bypass, there is regain. When I started doing it, I believed that this is the gold procedure and the end of all. But with time, you realize that any bariatric procedure that you do has a chance of weight regain. It's a chronic disease, and you have to treat it like a chronic disease. So any procedure that you do, as Carlos said, think of the next guy, think of the next procedure. So you have to keep that option open. But by and large, if you compare sleeve and bypass, the bypass, either Roux-en-Y or one anastomosis, shows more durability, which means the weight loss maintenance is more. So if you get all the pooled data for excess weight loss at 10 years, this is the meta-analysis. Roux-en-Y 56, sleeve 57. So this is a slight oddity compared to what we believe. And duodenal switch, any type of biliopancreatic diversion will have a higher weight loss, but it will have a much higher nutritional deficiency, especially protein calorie malnutrition. And then there is adjustable gastric banding. Now weight regain. So with sleeve 35 in first trial, 24 with gastric bypass. Then you look at the second study, sleeve 27, Roux-en-Y 13, and the third study on the right, comparing the RYGB, which has the lowest weight regain data. I'm getting more data to convince myself to start doing many. I'm ashamed to admit, but I am admitting it, Atif, for your happiness. Type 2 diabetes from the Stampede, which was alluded to, Phil Shower's trial, there was a clear statistically significant difference between sleeve and bypass compared to, and most of you know about this, diabetes remission and long-term durability. There's no doubt that with our bariatric operations, both in the SM-BOSS and sleeve bypass, it is Roux-en-Y shows better diabetes remission, at least in the short term. Similarly, resolution of dyslipidemia, hypertension, they resolve with all operations, but with sleeve the resolution at 10 years is less compared to gastric bypass. And similarly, obstructive sleep apnea gets better with all operations. With RYGB, it is 89%. Different studies, the conclusion is that the metabolic syndrome will resolve with almost all bariatric operations. And you have to choose what price are you paying to get those. And I think this is the important message. It's not that my operation is better than your operation. You have to tailor it according to what cost the patient is willing to pay, not only in terms of financial cost, but the health cost, the malnutrition, the sarcopenia. One important thing, which I think I've shared it in Pakistan, earlier on in my career in Nottingham, I had a patient, 100% excess weight loss, resolution of diabetes. I said, that is the patient who's going to be the happiest. And I met her 1 year post-surgery and I said, you must be delighted. And she said, I wish I never had the operation. And I was shocked. I said, what do you mean? You've lost all the weight, your blood pressure is better, your diabetes is better. And she said, I cannot be close to my husband now because I've got so much saggy skin. And I fought very hard to get plastic surgery for her. I could not on the National Health Service. And I made it a point to talk to all my female patients and tell them about the loose skin, tell them about the hair loss, because things that are not important for us as men may be vitally important for women and may have implications in personal lives for a lot of people. So as you get experience, you start getting the nuances of it, things that you don't see in the literature, but they're very important. So every patient needs to be tailored to a procedure and frankly explain that these are the possible problems, and are you willing to take these on as a price for gaining the health benefits, and some may choose not to. So it's very important to do that. So we know that cardiovascular improvement even in elderly patients with bariatric surgery is now, we have data even on above 70, significant cardiovascular mortality benefit. From SOS study, life expectancy increasing, and now there's meta-analysis proving that as well. So that's the sort of first half of the talk. How are we doing for time?
You're doing good. 8 minutes.
Okay. I can never make you happy, Carlos. So the complications, early that are within 30 days, late more than 30 days, and then the nutritional or metabolic which are long term. We all know that the dreaded complications of bleeding, leakage, or DVT, and mortality, 30-day mortality. More than 30 days, internal hernia or bowel obstruction, marginal ulcers, stricture at the anastomosis, which is not a real problem in one anastomosis, but it is a problem in Roux-en-Y, and gallstone development, and I think that's a separate topic. We will talk about it probably a bit later. I'll share our practice. And the nutritional deficiencies, dumping is a very important one, and can be very problematic in some patients, and despite everything else, we have in Cleveland, I think we have reversed a few gastric bypasses purely because of dumping. So it is an important, I tell my patients for any bypass that 50% chance that they will have dumping symptoms, and if they don't, they are happy and lucky. If they do, then they know that we have spoken about it. So it's better to talk about it preoperatively. So 30-day complication rate, Roux-en-Y has the highest, then sleeve, OAGB after that, and BPDS after Roux-en-Y. So that's the sort of, this is the anastomotic or staple line leaks. This is about 7-8 years old data used for this slide. I think in modern practice the leak rate should be less than 1%. I think luckily in our practice it's less than, it's around 0.1%. For bypass, for sleeve, I think we only had one leak in our entire series of total 4,000 operations. So bleeding is still more common from our data, but in any modern unit, the leak should be less than 1% for any procedure. On the right, there is a morbidity and mortality. The slide for the right extreme is magnified 10 times to make it pictorially identifiable. It's not 1% or 2, it's actually 0.1 and 0.2. Internal hernia, I have a talk tomorrow about it, so I'm not going to spend time pre-lunch on this. Just generally speaking, the incidence of retrocolic approach is much higher for gastric bypass. And the comment about OAGB, I know that it's not routine practice to close the mesenteric defect. We have treated at least more than 5 cases in Cleveland that came with internal hernia after OAGB. So it is an entity, not as common as Roux-en-Y, but I think there is more and more people are talking about closing it. Marginal ulcer, this has been a problem. I do hands-on anastomosis. And it has been a problem. When I started my practice in UK, it got better. I came to Cleveland, was a problem, got better. And then it comes like buses. I get, in 3-4 months, I get 2 or 3, and then I don't get any in 6 months, and I don't change any technique. So I'm still wondering about the technical part of it. The patient factors are smoking, non-steroidal anti-inflammatory usage. Those are the commonest that a combination of the two is the worst enemy. So we have patients before gastric bypass, we are very specific that we do not offer bypass if they're smokers, primary or revision. They have to stop smoking. What happens sometimes they start afterwards, and sometimes the electronic cigarettes they don't think as smoking. And we are publishing a paper, 3 vapes that came with perforation after both one anastomosis and ruined by bypass. And I was surprised that H. pylori infection is such a high risk factor. So when we're scoping patients with ulcers, we always do a biopsy for H. pylori and eradicate it when we find it. So dumping syndrome is 2 types. The early dumping syndrome is when this hyperosmolar food goes into the bowel and draws the fluid in from intravascular compartment, and it results in relative hypotension and then resulting tachycardia. And the late one is when the blood sugars go high and then the reactive insulin and it goes hypotension. Typically, when I talk to my patients, when I tell them pre-op about the dumping syndrome, I tell them you could have a fast heartbeat and you may feel sweaty or dizzy. You may have tummy pain and you feel like you're dying. This is how the patients described to me when they initially had it. Said, I thought I was going to die. I went and I lay down, and some of them will have diarrhea as well afterwards. So it's a combination of these. And as a bariatric surgeon, if you're doing any type of bypass, you need to know this, because these patients will go to gastroenterologists, they'll go to internal medicine, they'll have all sorts of tests, and all you need to tell them that this is a reaction to your sugary food. Sometimes they don't accept that they're eating sugary food, but they don't consider jam a sugary food sometimes. I had a patient I had to admit in UK because we couldn't figure out. We went through the food diary, and then we discovered he was eating biscuits and jam with breakfast. He had to stop his work because he could not drive the car. So it can be a very serious problem. 90% get better with dietary modification, okay? The additional 8-9% would need medication. 1% will be a problem, and you don't know what to do with them, and you find someone more senior who is senior enough and stupid enough to accept patients from you, and you dump it on them. So, but if you talk to your patients before surgery, at least they don't come back and say, you never told me that this could happen. So please talk to your patients before any bypass about dumping. Nutritional deficiencies, a lot of people have spoken about it. Vitamin D is a common deficiency before surgery.
1 minute.
Okay, thank you. So this is the key, perfect timing, Carlos. So I'll let you read this, and if anyone has any burning questions, I'll take those. Otherwise, I'll let Carlos finalize the proceedings.